So in the last video, we were looking at lung anatomy. We also looked at notes from First Aid 2020, any changes they made. There really wasn't much on this page per se. The only change was in the earlier embryology section, and we've already reviewed that. So everything else in respiratory, though, as far as First Aid 2020 is concerned, from what I know right now, there really isn't any other change. Nothing else. So on this page, there's a very important discussion here. Two important discussions on this page that are very high yield, but first aid really doesn't stretch the discussion that much at all. So I have a bunch of extra notes to really seal the deal here, because respiratory embryology and respiratory anatomy are just like really small topics. They can be discussed in one video, but it's not really enough to actually grasp what you need to know. Right now, where we are, we need to really have a good idea of understanding where inhaled foreign bodies go, right? Which, generally speaking, we all know, generally speaking, right, that it goes into the right lung, not the left one. And we talked about that a little bit in the last video. The second big topic here is how to do thoracentesis correctly. Right? Both of these are simple questions that you do not want to get wrong. There's just no reason to get it wrong. It's just basic understanding and a little bit of memorization. But for the most part, those are both going to be questions you will definitely see on your step one. And thoracentesis, and you don't want to get it wrong, because thoracentesis isn't just about the thoracentesis itself. Here it's a needle and you're doing this in a hospital setting, but this could also just be a stab wound or someone getting hit or having a rib fracture, and then they ask you, what happened? Is the rib gonna puncture the lung, puncture something else? So you need to make sure you understand that. So in the last video, we did a good job. We already covered what's happening with the inhaled foreign bodies, right? And there's one little thing though. We did this question down here from Amboss, right, where a 2-year-old girl was eating something and swallowed a watermelon seed, and they wanted to know where it would go. And only 28% of people were able to get this answer correct. They chose the right intermediate lobe bronchus. That's what they wanted you to pick. Many other people chose the right middle lobe bronchus, but you know from your experience and from your studying that it never goes in the middle, right? That's not one of the most likely answer choices. It's either going to go, if you're laying in bed while supine, it's going to go in the right lower lobe. If you're standing up, it's going to go in the right lower lobe. And if you're lying on the right side, then it's going to go in the right upper lobe, but never the middle lobe. So about 50% of people, right, 49% here, about 50% of people chose right middle lobe bronchus because they couldn't really understand what the right intermediate lobe bronchus is. So I added a picture here to show you what that is. So you can see on this colored image over here, you have the left one and you have the right one. And we're concerned with the right because everything goes in the right. The only time the answer is ever going to be the left is if the person was actually laying on their left, right? Then it's more likely that it's going to go in one of the left side things. And even then it'll go, you can see how nicely it can just go this way and then go down here, right? Rarely ever in one of those upper areas. So now this is the intermediate, right? And that's what they wanted you to pick as an answer choice. You know that something coming down on a baby that's sitting up and eating watermelons, something coming down this way is going to go into the intermediate and then go in the lower lobe, not the middle one. The green one is the middle lobe here. The pink one here is the upper lobe, which also was in the answer for this 2-year-old girl. So if you were wondering what the intermediate bronchus is, that's this one right here. This intermediate bronchus then divides into the green middle and the darker lower lobe, right? So these colors are just there for discussion purposes. Zainab, oh, I already took mine. I took my step one already. So this is one topic, and we're done talking about that. The next thing is understanding the paracentesis stuff, the thoracentesis stuff, and understanding how fractures or any kind of stab wounds in any of these areas can affect you. So the first thing you want to understand, right, in this U-World image over here, they've kind of labeled the 6 to 8, 10 to 12, and 8 to 10 here. I really wish they had the 10 to 12 last, so I like studying it as 6 to 8, 8 to 10, 10 to 12, right? That's the order it's going in. And it's a map, right? Mid-clavicular, mid-axillary, and paravertebral. So mid-axillary and paravertebral, that's kind of how I remember it, the map. and the map goes from 6 to 12, right? So I would rather switch these two images with each other if I could, but it was actually I could just edit this out and move it over, but then I would end up cutting the words over here, so I didn't do it. But the main thing is you need to memorize those numbers the way they are, because if you're ever doing a thoracentesis means that you're gonna go ahead and inject in the pleural cavity and then get the fluid from the pleural cavity, right? And if a person has an infection, a person has any kind of pleural effusion, you can drain that pleural effusion out and then examine it and see what's in there, right? But you can see how easy it is to fuck up. If you're off, you can actually end up puncturing the lung, which will obviously hurt, right? And obviously make it very hard for the patient to breathe correctly. And if you fuck up too far down, you can puncture the liver if you're on the left side, and you can see how. Sorry, if you're on the right side, and you can see how they show you that on this image. Right? You can see you have this really big liver on the right side under your lung, and if you miss, if you didn't count the ribs correctly or anything else like that, you're gonna end up puncturing the liver, and that's gonna hurt really problematically. So now here, we did a question, and I actually ended up cutting off the video from the last video. We already did this question in the last video, but I edited the video and cut it off because I wanted to have the whole discussion in one video. So let's take a look at this question and then really try to understand the numbers and what's happening with thoracentesis. So this question says, a medical resident performs a diagnostic procedure on a 32-year-old male. He inserts a needle along the upper border of the 10th rib at the right mid-axillary line. What is the most likely to be punctured as a result? Right? And then they have all these answer choices. 51% of people got it correct, which is liver, but 28% of people thought you might actually end up puncturing the right lower lung lobe. And that can't really be possible, right? It can't, because the right lower lobe, as you can see in this image, this is the anterior view, the lung only comes down to, from the front, only comes down to about the 6th or 7th rib, right? You can see that between the 6th and 7th, that's it. So if you're on the right mid, and this person is doing the mid-axillary line. So in these two images, you don't see the mid-axillary. It's just showing you the mid-clavicular and then the back. So here you can see the mid-axillary. In the mid-axillary area, the lung comes down to the 8th and the pleura goes up to the 10th. Right? And this resident was doing it above the 10th somewhere, and you can see how it is possible to puncture the liver there. Right? You can puncture the liver there, and you can see the big brown liver is in that area. It's probably best, if you're going to do the mid-axillary line, it's probably best to use the 9th rib, above the 9th rib, to do it. Right? That way you don't exactly hit the liver, but you also don't hit the lung, and you get enough space in between to just get the pleura. And that's what this image here is kind of showing you, right? Because it's a little hard to do it on the right side like that, on the mid-axillary line. I don't even know why you would need to do it that way. It's probably best to just get it from the back. The back is the easiest place, because you can see how much pleura there is in the back, right? There's a lot of space to work with in the back. Much easier. Right? So this explanation here tells you that the lower border of the lung is usually 2 intercostal spaces above the respective pleural border. And that's what you can see. Right? The lung goes up to the 6th and the pleura goes up to the 8th in the mid-clavicular line. In the paravertebral on the back, the lung goes down to the 10th and the pleura goes down to the 12th. And then the axillary line, you have the lung going to the 8th and the pleura going to the 10th. So you do have to memorize this, and you can use whatever you want to. I memorize it by just writing MAP, right? Some MAP for mid-clavicular, right? Axillary, and then paravertebral. And then from there, you just know the numbers 6 to 12, so it's 6 to 8 first, then it's 8 to 10, then it's 10 to 12, right? So those are the safe areas for you to go ahead and do your thoracentesis. That's the numerology I would use to memorize where you can do thoracentesis, right? But I use just remember to swap this image with this one, so it's MAP that way. Otherwise, MPA and the numbers aren't exactly working that way either. But as long as you can remember it like this, you can't fuck that up, right? So this resident didn't remember it correctly, and he most likely did end up puncturing the liver, which isn't the worst case scenario. The liver is going to regenerate. It's just that he's not going to be able to get the pleural fluid correctly, and then now he has to take the needle out, he has to get another needle, which costs money, and then he has to go in again, which is obviously going to be very problematic for the patient. You don't want to keep getting stabbed, right? So patients can complain about that, and of course patients always complain in America when they get the opportunity to, because they have every right to, and you can make good money if you can complain about something you could sue for. So that's stuff you have to really watch out for, right? So that's the whole concept of thoracentesis. Make sure you understand what this whole pleura job is, right? So this is your parietal pleura. The parietal pleura is the outer part that's stuck to the chest wall, whereas the visceral pleura is the pleura that's stuck to the actual lung itself. And in between the visceral and parietal pleura, you have some pleural fluid that you can absorb, right? You can get out, and then that's what you want to collect and examine. Alright, so very important to make sure you understand both of those things, where the anatomy of things are, where people can get stabbed, because this same thing you can get in a stabbing question too, like we did in this one up here from UWorld, right? Someone can get stabbed along the midclavicular line between one of these ribs, on the paravertebral line if you got stabbed from behind between one of these ribs, or someone can get shot by a gun in one of these side ribs, right? So you have to know where the bullet might have punctured something, and etc., kind of silly questions they can make up. Just be ready for that, right? So if you remember this, you'll remember how far down the liver goes and how far down the pleura goes, right? So 6, 8, 10 is the extent of the liver, the lung itself, not the liver, how far the lung goes. So 6, 8, and 10 is the extent of the lung itself. After that, you have 2 more spaces where the pleura is going to be occupying it. That's the purple area. And then everything else is just other stuff. Also remember your diaphragm, right? Where is your diaphragm? So the diaphragm is actually right up here, right? Your lungs are sitting right on it. So your diaphragm is right up there, and then you have your liver under that. Okay, so very important to remember that anatomy as well. And of course, remember the phrenic nerve, right? The phrenic nerve travels around this stuff, and you can have irritation of the phrenic nerve anytime you touch it at any of these levels, right? So you can have referred shoulder pain, you can have difficulties with your diaphragm working correctly, all kinds of other little scenarios like that. This image, the diaphragm structures, this is just pure memorization for just a little bit of knowledge, but nothing crazy. So here they tell you structures that are perforating the diaphragm. So at T8, the inferior vena cava and the right phrenic nerve are going to perforate the diaphragm. At T10, the esophagus and the vagus nerve are both going to be coming out of the diaphragm. And at T12, you can see the aorta and thoracic duct, as well as the azygos vein, the red, white, and blue. Right, so T12, it's the red, white, and blue. There's just memorization techniques. At T10, cranial nerve 10. At T8, inferior vena cava and right phrenic nerve. Right, so this is pretty incomplete. That's not everything. There's the right phrenic nerve as well, so don't forget that in T8. And T10, you have your esophagus, and of course the 10 reminds you of cranial nerve 10. And then at T12, red, white, and blue. So you have to remember all 3 of those things. The diaphragm is innervated by C3, 4, and 5 through the phrenic nerve, which is what we were just talking about. So pain from the diaphragm irritation, such as air, blood, or pus in the peritoneal cavity, can be referred to the shoulder and the trapezius ridge. So this is where patients will come in and tell you they're having right shoulder pain or left shoulder pain, right? And then you're supposed to think, okay, shoulder pain is related to phrenic nerve. Phrenic nerve is related to the lungs, the chest, and your diaphragm. That's very important. C3, 4, 5 keep the diaphragm alive. I8, 10 eggs at 12 is another memorization sentence that I did use when I was first studying. And then other bifurcations. So we saw a lot of bifurcations when we were in GIT looking at the aorta, right? And where the aorta bifurcates and what happens over there. Here they're telling you that the common carotid bifurcates at C4, the trachea bifurcates at T4, and the abdominal aorta bifurcates at L4. And we already saw this last one earlier. So this is actually pretty nice because everything's out of 4. Right? So the carotid, C4, trachea, T4. Instead of the 4s that they've highlighted here, I'd like to rather highlight the C. Right? So the C for carotid. This C is C4. The trachea is with a T, so the trachea is T4. And then abdominal aorta is really far down anyway, so you know that's going to be L4, right? So that's another way to memorize all of that stuff. And that's really it for that. Nothing else over here. Now, there's a couple questions we didn't do, so I want to go ahead and revise those real quick, because these are also related to the anatomy of the trachea area and all that, and you can get silly questions on it. So this is a Netter's anatomy image showing you the muscles in the throat, right? You have your stylopharyngeus, your pharyngeal constrictors. What else is over here? Your stylopharyngeus is on both sides, and that's a really big one because you get the stylopharyngeus questions, swallow stylishly, the embryology questions that you can get. We did that when we did reproductive. And that's, right here, you could see there's a nerve, and that's something that's pretty important. You can get questions on that. Any kind of injury in this area, you can get questions on. And this is related to that. So here, a 23-year-old man comes to the emergency room complaining that he has food stuck in his throat. His symptoms started 2 hours ago after eating fish at a local seafood restaurant. So it's most likely a fish bone, right? If he was a 50-year-old man, then I would think of elder Mike and that he might have like a space in the back of his throat that is accumulating food and causing him to have bad breath. But that's not what's happening here. He's a young guy with most likely a fish bone. So now he has tried coughing and swallowing multiple times to clear the food, but has so far been unsuccessful. He denies any difficulty with breathing, does not appear to be in any distress on physical exam. During an attempt to retrieve the fish bone, a nerve is injured deep to the mucosa overlying the recess. What is most likely impaired in him, right? So this recess thing that they were talking about is what I really wanted to show here. They didn't really necessarily label the recess, right? So what did I write? I didn't write it down. Okay, let's take a look. So what is most likely impaired in him is going to be the cough reflex, 36%, while 55% of people chose the gag reflex. And if you don't remember which nerves are involved with these reflexes, then that's something you need to go back in neurology and take a look at. The piriform recess, which should have been labeled in this image, but isn't, or am I not seeing it? Because it's supposed to be this area right here, this thing, right? So that's where you have your nerve. So the piriform recesses are small cavities on either side of the laryngeal orifice. During normal swallowing, food is diverted by the epiglottis laterally through the piriform recesses into the esophagus without endangering the airway. A thin layer of mucosa overlying the piriform recess is all that protects the superficially coursing internal laryngeal nerve, and you need to remember that. That's the nerve of the vagus nerve. A branch of the superior laryngeal nerve of cranial nerve 10. Unlike the recurrent and external laryngeal nerves that carry motor fibers to the muscles involved in vocal cord function, the internal laryngeal nerve contains only sensory autonomic fibers that mediate the afferent limb of the cough reflex. The afferent limb of the gag reflex is mediated by cranial nerve 9, glossopharyngeal, while the efferent limb is carried by cranial nerve 10, vagus nerve, and that's not going to be affected. Right, so you do need to know the difference between the gag and cough reflexes and what nerves are involved. Very important to know this. And page 529 over here, I wrote it, so let's take a look at it real quick. This is the page in neurology, but I don't think it's 529 anymore because I added more stuff. So let's take a look. Should be in, let's see, gag. No, the other way. Yeah, right here. So this is page 549 now. Okay, so you can see how the gag reflex, right? Just like we said, gagging is a throat thing, so glossopharyngeal cranial nerve 9 is involved in sensing it, and then efferent is cranial nerve 10, vagus, okay? And that's the only thing here that is related to the gag reflex. So that's why a lot of people chose the gag reflex. No one really thought of picking cough reflex or anything like that from that question, so be ready for that. The only way you could have gotten that question right was knowing that it wasn't the gag reflex. The gag reflex is not going to be the thing that's affected because although cranial nerve 10 is part of the efferent part, the question is asking about a different nerve. That's the internal laryngeal nerve, and that one is it's only sensory. It's only sensory. It's very important to be able to just know this little thing. I mean, the cough reflex isn't really a actual big time reflex, and it's not really discussed in the book, but the coughing aspect of things that we do because something irritated our throat is a cough reflex, and is due to the internal laryngeal nerve sensing that. Okay, so this is what this question was teaching. Other than that, there was one more thing that we skipped over from here. So we did this stuff. We understood phosphatidylcholine and sphingomyelin, and how they're labeled on this graph. This one is an X-ray from Amboss, and this is the stuff I love Amboss for. So you can see the normal, and then this one where it's kind of marked now. In the normal, with the untrained eye, you might have not actually noticed this, right? The way it's highlighted here. So below are X-rays from an infant with neonatal respiratory distress syndrome. You can see the overlay is showing air bronchograms as a result of surfactant deficiency in grade 3 respiratory distress syndrome. Right, so you know this is an infant because the way the chest cavity is shaped here is really, really small ribs. Right? It's a baby. And the fact that you can see air in this area, the way this is green highlighted, that's showing you that there's surfactant deficiency, and this is really bad. Right? In fact, the lungs itself don't really show clearly. It's all grayish. Right? This is all supposed to be, the lungs should be full of air and look like this, black. But they're not. They're empty-ish. They're very, very grayish, right? In fact, the grayishness is actually described when they talk about it, right? Neonatal respiratory distress syndrome, the grayishness is described as a ground glass appearance, right? Because the lungs are not filling up with air, which would make them black. That's one thing. And then this stuff, right? So very little topic, but an easy one you definitely don't want to fuck up. The concept of HPV causing laryngeal warts, right? So let's take a look at all these questions that are talking about it and what's so special about this. So a small DNA virus is described that has affinity for stratified squamous epithelium. The virus is most likely to affect which of the following respiratory structures? And the answer was the true vocal cord, which sure, a few more people got correct, but generally speaking, people are everywhere. No one really had a good idea, right? True vocal cord was probably, there's a very good chance that 33% is the biggest number here because people are like, I don't know what the fuck everything else is, but true vocal cords is probably the correct answer, and then they picked it. But there's no telling if any of these people actually knew what the correct answer was. Of the answer choices listed, the true vocal cords are the only area covered with stratified squamous epithelium. The virus described could be HPV, which can cause warty growths or papillomas on the true vocal cords, as this image I've shown you right here. Producing hoarseness and possible stridor, upper airway obstruction, right? Other than that, the false vocal cords, the other thing that's right here, right? The laryngeal vestibule, which isn't really that important, but the laryngeal vestibule is the space at the top of the larynx, bordered by the lower half of the posterior epiglottis, and by the vestibular folds, or the false vocal cords, right? The vestibular folds are your false vocal cords. The region of the upper airway, this region of the upper airway is lined by ciliated, pseudostratified, columnar, mucus-secreting epithelium. Completely different, right? But our actual true vocal cords are stratified squamous. And it's squamous because when you talk, yell, shout, whatever you might do, go for a big party and shout all night, you actually end up rubbing off. Just like you rub off skin, you rub off a lot of your true vocal cords, and then you have to wait for a little bit of time for your true vocal cords to regenerate. Right, for the stratified squamous cells to come back again, and that's the time it takes for your voice to go back to normal again, right after a big night out. And it's very important to know that. So HPV, warty growths, papillomas, true vocal cord, stratified squamous, simple little things that are going to be tested. And BME 18 also had a question on it. A 6-year-old girl is brought to the emergency department by her father because of a 15-minute history of severe shortness of breath. The father says that she was diagnosed with the throat tumor 3 years ago. Her respiratory rate is 32, and physical exam shows nasal flaring. Laryngoscopy shows multiple raised, finger-shaped lesions arising from the vocal cords and epiglottis and partially occluding the larynx. The lesions are excised. Microscopic exam of the lesions shows finger-shaped fibrovascular cores lined with benign squamous epithelium. What is the most likely causal virus? There was no thinking here. You just pick HPV type 6 and you move on. The finger-like thing that they're talking about is a papilloma, right? Papillomas are often described as finger-shaped or nipple-like. Either one of those things are common things they can use, right? So the tip of your finger looks like a nipple, and both of those are interchangeable descriptions for a papilloma. And if you have something like that in the laryngeal area, that's HPV. That's it. You just pick that, you move on. Very simple stuff, nothing crazy, right? So you can see your false vocal cord here, and then the true actual vocal cord, which does not secrete mucus. It's just there for talking purposes. All right, so that's basically it. We're going to see a lot more x-rays like this to master stuff, so be ready for that. Neonatal respiratory distress syndrome is a big one. And now, after seeing the highlighted form, you should be able to see this much more clearly. And that's a bronchogram showing you that air is in this, but it's not in the lung. Right? So air is reaching the tracheal stuff and the bronchioles, and well, it's reaching the deep bronchus, but it's not really going into the lung. The lung isn't doing much with the air. So that was a sign of neonatal respiratory distress. In this entire area like this, the gray stuff, that's what's called a ground glass appearance. All right. Other than that, everything else is okay. The stomach is okay. You can see the stomach has some air. This is the duodenum right here. That's all normal, right? So nothing else to be freaked out about. And that's basically all of respiratory embryology and anatomy, right? The last thing here is just bronchopulmonary segments. You do not need to know bronchopulmonary segments for step 1 at all, but it's just something nice to have a visual understanding of, okay? So this is just showing you how your lung actually breaks up. And remember, this part here is your intermediate bronchus, right? So that was one of the answer choices in Nambaugh's question. So yes, anything you swallow by mistake into your trachea will go in the intermediate bronchus and most likely go in the lower lobe. Nothing ever really goes in the middle lobe. And if you're lying on the right side, then of course as soon as it comes down here, it's going to go into the upper lobe, not the middle or lower lobe, right? And that's just something you just have to memorize. This stuff was something I added when I saw a lot of questions asking about people getting stabbed, right? Depending on where you got stabbed, this man here with the labels is showing you what lobe of the lung can get injured. That's all this is showing you. So if you want to use the image for a little bit of studying, or if you ever see a question where you need this kind of image, you can find it and then try to really grasp what's happening. Right? So oftentimes people do get stabbed, and when they do get stabbed, it's important to know what's getting injured, right? And most times you can see the answer is probably going to be the lower lobe of the lung, because the lower lobe of the lung encompasses the major part of the back as well as a good portion of the side that's vulnerable, right? This is a vulnerable part of your sides that can easily be stabbed. So very important to know that. Very rarely will someone end up hurting you in your upper lobe of the lung from the sides, because your shoulders are usually down and covering your upper lobe. And then in the front, yeah, your upper lobe can be injured, right? But not the lower lobe, because the lower lobe is majority in the back. It's very important to understand that the lobes of the lung are unfortunately not just little squares sitting on top of each other like that, right? So you have your lower, middle, and upper. It's not like that. They're actually pretty slanted, and that's what's showing you over here. Okay, they're very slanted. They're just named lower and upper because of the position they're in, but they're not stacked. They're actually very slanted, and that's why these images are all slanted. These lines are all slanted. So the back is all lower lobe of your lung. The front is mostly upper lobe of the lung, and that's it. Especially on the left. The right side has a middle lobe very close to the nippular area. So if someone got stabbed really close to the nipple on the right side, you pick the middle lobe. But that's it. Alright, so that's the end of all of that. This question is just a very easy question on alpha-1 antitrypsin deficiency. Nothing crazy. You can check that out when you want. And then in the next video, we'll go into respiratory physiology. Thank you very much for joining, and Happy New Year to all of you guys.